This is Franklin's Case, Grand Rounds Clinical Presentation by Jill McConnell. Tried to make this look as much like a patient file as I could. So we're just starting with an empty file and the referral from Franklin's primary physician. Franklin is 69 years old, African American male. He's been married to Maggie for 45 years. She was the one who originally brought him to his primary physician, saying that he had not been sleeping at night, has been acting agitated, and seems not like himself. His primary doctor noticed that he seemed to be moving slowly and was irritated about being at the doctor's office. Franklin reported that he hasn't been feeling like himself since he retired. And the doctor completed a depression screening, inventory, and neurocognitive screening exam, referred to a geropsychologist for further evaluation, but did not have the results from the interview available at this time. Franklin asked if his wife could stay with him in the interview, and he held her hand. A quick health history questionnaire. Franklin himself has arthritis and hypertension. His mother passed away from a heart attack, and his father may have had dementia, but there was no mention of an actual diagnosis. So, interview notes, just as I imagine I would probably be writing in an interview with a client. Franklin graduated from high school, but states he was never a great student and did not go to college. Grew up with his parents living in poverty. He worked for the same construction company in New Jersey for 42 years, working his way up from a laborer to security supervisor and union leader. During his work with the company, he experienced a number of racist incidents, including being called racial slurs by supervisor and clients. Even when he was a union leader, he often felt as if he was treated like a laborer. Maggie worked as a first grade teacher until she had their son Michael, and then became a stay-at-home mom. They struggled to make ends meet until Franklin got his final promotion as supervisor and union leader, and then felt that they were finally secure financially. His friends had visited after his retirement, but lately they've been not able to come to his home due to their own poor health. He's physically fit except for his issues with high blood pressure and the more prominent problem of having arthritis in his knees. He's struggling with his knee ailment. As he used to be a bowler, several of his friends bowled with him, and they would bowl together. Um, Even after he started having problems with his knees, Franklin would still go to the bowling alley and watch them, but noticed that he would get upset at times not being able to participate. His only other hobby mentioned was gardening, but his knees also make it a challenge for him to kneel down to pick weeds or pick vegetables. He denies difficulty with his appetite, stating that Maggie's a good cook. Franklin reports being frequently mad and frustrated, as well as being embarrassed, having little accidents, spilling food, knocking things over. Started asking Maggie to drive him to work because he'd caught himself veering off the road at times and barely avoided an accident. He told Maggie that it was all the stress and that he just had too much on his mind. He retired recently, within the last year, because of his worries that he was going to mess up something. Sometimes doesn't know what time of day it is or what day of the week. He states he doesn't know what he had for breakfast this morning. Has to ask for assistance to walk even short distances, otherwise he must stop to sit down or he will fall. He states he finds nothing in the world more infuriating than knowing that he knows something but can't remember. So after the interview, Again, I imagine I would be taking down some notes, and one thing I would make note of is that after the interview, Maggie stopped to talk to me herself and has been worried about her husband. The other day, he couldn't remember what the toaster was, and then later in the evening, he thought that she was his mother. Franklin seems to be unaware of these occurrences, but she is concerned about what she should do when this happens in the future. So I think the first thing, most obvious, would be a neurocognitive disorder. There's been a substantial decline, forgetting his grandson's name, can't remember what he had for breakfast, knowing something but can't remember, and not knowing day or time. Um, his attention has also had a substantial decline, veering off the road while driving due to inability to focus is a major one. Um, Also, probably part of the reason that he thought he might mess up at work, and he's kind of attributed it to having too much on his mind. Perceptual motor skills, there's been a modest decline. Franklin's primary doctor noted he was moving slowly. And then Franklin having small accidents, spilling things, knocking things over. And it may also contribute to his falling and needing assistance walking, in addition to the arthritis. Planning and decision making, there doesn't seem to be any real decline. He decided for himself that he thought it was time to retire, and he seems to be aware of his own mental decline. His language ability, just a modest decline, not being able to remember a word or name. Social awareness, no decline. He's worried about his hurting his grandson's feelings for not remembering his name. Concern about what his peers at work thought of him before and during retirement. And then he wants to keep his wife happy. He doesn't want her to worry about him. So I went through the checklist and feel like there's enough evidence here of a major disorder, major cognitive disorder. Um, Alzheimer's disease is the most common type. At least 2/3 of neurocognitive disorders are Alzheimer's related. And most cases happen after the age of 65, 3% of people within his age bracket specifically. And then 17% of people ages 75 to 84. So likely there will be some increase in this as he ages. And then he has mild memory problems, and this will probably become progressive. Lapses in attention, difficulties with language and communication. As the symptoms worsen, the client will have difficulty completing complicated tasks and remembering important dates or appointments, more confusion about time and place, wandering, and may begin to show more poor judgment. Eventually, he'll have trouble with simple tasks and most memories, and there will be changes in personality. He will become fully dependent on others and fail to recognize close relatives, friends, and will likely continue increasing being uncomfortable at night. Memory impairment is the most obvious cognitive dysfunction. Normal for patients to try and deny the problems, as Franklin seems to kind of want to at least minimize the problems. Typical for sufferers of Alzheimer's to become depressed and to be agitated about their mind state. Up to 40% develop depressive disorder of some sort. Franklin's primary doctor noted that he seemed agitated about his visit. Normally, patients maintain reasonably good health, but eventually become less active, spending more time sitting or staying in bed. And Alzheimer's cannot be fully diagnosed until after death, examining changes in the brain. Later, we'll talk about uh, there is testing that can be done to verify a likely diagnosis of Alzheimer's. But the cause of the disease is not fully understood. Doctors and scientists know that the explanation does lie pretty centrally on senile plaques building up and neurofibrary tangles. Um, and those build up over time, making the disease progressive. Some genetic factors. It's usually a contribution. Individual whose parents, like Franklin's father, may have um, suffered from the disease are more likely than others to develop Alzheimer's disease. Specifically, something to look for would be the ApoE4 form in his genetics that could have been inherited from his father, and it makes people especially vulnerable to Alzheimer's disease. So now I'm going to talk a little bit about Franklin's thoughts of himself, which is something I think is important, is how a client views themselves. So I just wrote down, as if it was on little sticky notes, some quick items that kind of lend themselves to how Franklin sees himself. So he was afraid that his grandson thought that he didn't care for him or love him because he couldn't remember his name. He said, I spent my whole life trying to be sharp, but I ended up as a failure. I can't do any of it anymore. I just lay in bed. I provided for my family and I did my job, and now it's all gone. Feeling of loss after retirement. 69 years old, who needs a woman to take care of him like he's 90? What use am I? A lot of these kind of illustrate his negative view of himself, his feeling less able than he has before in his life. Thinking that others think he's going to screw something up. Questioning why he would want to get up in the mornings is a red flag. He feels like he's being put out to pasture, and he's concerned that his family may try and put him into like an assisted living facility. So I want to touch a little bit on possible depression here. It's common for people with physical ailments such as the arthritis as well as Alzheimer's disease. His emotional symptoms present that he's feeling like he can't do things anymore. He's embarrassed about needing more help, despair over no longer working and providing for his family, and dreading not being able to make his own decisions in the future. Motivational symptoms present would be questioning, why would I want to get up in the morning? Probably lends itself to why he is in bed or sitting most of the day, most days. Behavioral symptoms include spending more time alone, staying in bed for longer periods of time. It was also mentioned that he naps. Cognitive symptoms present. He thinks that he's just going to screw up. Finally, or feeling like he ended up a failure, believing he's a drain on his wife and his former employer, thinking no one will ever trust him with anything because of small failures. And physical symptoms present, again, the sitting down and laying in bed most of the day, taking naps. These symptoms are exaggerated, of course, by his arthritis and the fact that he's up at night wandering, not really getting good sleep. So, an increased depressed mood, decreased enjoyment, or less interest in activities. He's not been able to do his gardening. He's not been able to go do his bowling. He's not seeing his friends as often. There doesn't seem to be any weight or appetite changes. No real insomnia. Um, More of kind of a delirious state. Agitation related to having his neurocognition decline, reduced motor activities related also to his arthritis, but could also be because of depression. Fatigue as well, the same thing. Him being up at night wandering is keeping him from getting good sleep and not remembering that he has been doing this at night would probably lead him to believe he did get a full night of sleep and feels fatigued. Feelings of worthlessness and excessive guilt are present and are a concern, probably the biggest concern as far as the state of depression goes. Reduction in concentration related to his neurocognitive disorder. It's likely that Alzheimer's is making it more difficult for him to concentrate. But it could also, again, be partially due to depression. But I think also really important is no mention of suicide, no specific mention of death or harming himself. Really just kind of that feeling of, why should I get up out of bed? Not as much the, why am I still here getting up out of bed? So again, just the checklist for a major depressive episode. I don't think that he has long enough history of depression at this point to diagnose any major depressive or lasting depressive diagnosis. Now, delirium is something that seems to be happening, and Franklin does not realize it, does not remember it, which seems to be kind of typical. He's had episodes of disturbance in attention and orientation to his environment, as far as not knowing the day and time, and also the just kind of overall general loss of attention. It's typical for sufferers to focus on becoming less, or their focus is becoming less clear and more difficult. Concentrating, thinking in organized ways leads to misinterpretations of what's going on in reality, illusions, sometimes hallucinations. I think this is really indicated by his confusion about thinking his wife was his mother. And then also the fact that Franklin has stated that he feels kind of like being awake isn't much different from being asleep, but it's actually more confusing. State of massive confusion that lasts over a short period of time, like hours or a couple days. So I think this time frame also fits well with the episodes that his wife has described and himself described. Losing concentration and focus on his driving a little bit, but more so like the word confusion, being up at night, not recognizing his wife, thinking that she's his mother, um, and then him not remembering it in the morning. So there's brief checklist of delirium, which I feel like he does fit both of those criteria for very short periods of time so far. So my diagnosis is going to be major neurocognitive disorder due to Alzheimer's disease. And I think he's transitioning from the early and more mild stages of Alzheimer's to the later stage, having more of the major neurocognitive disorder. And the criteria for that I believe he matches is a substantial decline in memory and learning, a substantial decline in attention, and the fact that these cognitive deficits are interfering with his ability to be independent, not being able to drive himself to things anymore, needing his wife to take him to appointments, um, her having to guide him back to bed at night. I think there is a little bit of depression going on as well, probably more of a depressive episode, and probably situationally related to the other things that he's going through. Um, Most of his depression symptoms are comorbid to either his arthritis or the Alzheimer's. And episodes of delirium, I think he's experiencing fluctuating disturbances in attention and orientation to his environment, and that he does display some cognitive disturbance. So for trauma-informed care, I just kind of listed out the 6 major points and made some notes as to how these are and will be addressed. So for safety, the primary reason that Maggie brought Franklin to the doctor in the first place was because she's worried about his physical safety as well as the mental issues that he's having. So I want to work with both Franklin and his wife to develop strategies to help ensure his continued safety in my office and when they're at home, when they've left. So I want to help teach Maggie also some strategies for keeping him safe at home as well. Trustworthiness and transparency, just discussing the importance of being mutually fully truthful with each other to achieve the best outcomes. We have to have as much information as possible to be able to give the best therapies and treatments and to come out with the best outcomes. Um, and then talking also about confidentiality, that I can't tell Maggie or anyone else what Franklin tells me in confidence unless I think he's going to be a danger to himself or others. And that if he requests for Maggie to be in the session or appointment with him, I can't say anything that is said by either of them during the session um, to anyone else again, unless I think that there's a safety issue. For peer support, I think meeting other people who know from their own experiences what Franklin and Maggie are each going through is important. Using their other people's experiences to promote healing and establishing hope and safety and trust within their couple and their group and with their new peers. Referring each of them to a group for Alzheimer's sufferers and Alzheimer's caregivers, and recommend looking within their own communities that they're already part of for support. Like for if they go to church or with their neighbors or whatever communities they already exist in. Collaboration and mutuality. I want to foster the belief that people being served is the primary focus of the organization that I'm with. Individual strengths and experiences are recognized and built upon. So, recognizing what Franklin does when he's in these situations where he's confused, um, and using other people's experience to help him build better strategies. Belief in the ability of individuals, organizations, and communities to heal and promote recovery is important. And Franklin and Maggie may want to consider relocating to a retirement community for added support, more collaboration. Empowerment, voice, and choice. I want to support Franklin in shared decision making and goal setting to determine a plan of action for him. Focus placed on partnering and leveling power differences between staff, client, organizational staff, making sure that what I'm telling a client is the same thing that they're telling a client at the front desk when he's scheduling another appointment, that kind of thing. Everyone has a role to play in working together for the best patient outcomes, and we want to empower those collaborators. Cultural, historical, and gender issues, looking within their current communities for support means that they are working with social groups where their family already has roots. And then looking for resources that are responsive to racial, ethnic, and cultural needs of Franklin and his family, as well as recognizing and addressing some of the past trauma, racially prejudiced, and possible discrimination against Franklin in his past, especially pertaining to his past employment. So, for a treatment plan, our primary goal stays the same on each slide. Maggie, their son Michael, Franklin's extended family and friends, myself, the support staff that I have available, Franklin's primary physician, a specialist that he may start to visit, any other therapists that he's working with, and groups of peers, group therapy, that kind of thing. All recommended for his treatment to be brought on board, working to help achieve the best outcome for Franklin. For his neurocognitive disorder, I think group therapy is important so that he can receive support from peers who are going through the same things that he's going through, and learning new coping strategies. Maggie, I think, should be seeing a support group for caregivers. Franklin and Maggie's son Michael and any other close friends and relatives are recommended to read about Alzheimer's disease. And we could maybe bring in some additional assistance from outside into the home with visiting angels, which we'll talk more about at the end. Long term, looking at maybe moving into a retirement community that offers a blend of independent living, assisted living, and potentially eventually medically assisted living. Depending on the results of further testing for Alzheimer's, um, such as blood work, brain scans, the surveys that Franklin did with his primary physician, um, we may want to have Franklin start using neurocognitive drugs that are designed to affect acetylcholine and glutamate neurotransmitters, which play a role in memory. Cognitive behavioral treatments would primarily focus on behavior, both physical therapy for his knees would be helpful, Pilates, yoga, or swimming, gentle exercises, whatever he can do to stay physical as much as he can within the confines of his physical ailment, and focus on changing the everyday behaviors that can be stressful for his family. And that can be done through a combination of role playing, modeling, and then practicing with the family on how and when to reinforce his positive behaviors. For his depression, as with younger people, it could be helped by cognitive behavioral therapy, as well as interpersonal psychotherapy, antidepressant medications, or a combination. Both the individual and group therapy formats can be very helpful. Antidepressant drugs are generally not as good to use with elderly patients because it can be difficult to judge the efficacy and safety of the drugs interacting in the body of an older patient and it breaking down differently. And it can also cause risk of causing further cognitive impairment. So for this time, I'm not inclined to use medication for Franklin unless his primary physician recommends based on the depression survey. My recommendations for him and his family would be I would like to request the results from the depression screening and inventory and the neurocognitive screening exam. And then, depending on the results of those screenings, the physician will probably order blood work, potentially brain scans to look for biomarkers. And in blood work, what they would be looking for as an indication would be a large number of beta amyloid proteins and tau proteins, which are the building blocks of those plaques and tangles that are thought to be primary cause of Alzheimer's disease. I'd like to get a perception and motor performance benchmark now to compare to future retests. Just intermittent, probably every 3 months, at least to start with. Giving Franklin resources, referral to start working with group therapy and doing research into Alzheimer's while waiting on the test results. I also want to give Maggie some resources for caregivers. Make sure she has a therapist available to her for her feelings and I guess, emotions around what's going on with her as the caregiver, as well as having support from other caregivers in like a group setting. And referring both of them to a resource that they can use together, which is Visiting Angels. And that's the resource that I'm going to talk most about. So I would give them something similar to this. It's just kind of an informational, quick reference for Visiting Angels, which is living assistance services throughout America. They have different branches. Our local branch would be Visiting Angels of Westerville. And they look to customize care to meet all of the loved one's needs, which would be Franklin. Their services are designed to provide compassionate care so that Franklin can continue living at home. No matter what health or wellness needs they have, Visiting Angels will guide them to a care plan that fits them best. I've also provided the website if either of them want to do more research into it. But some of the home care services offered by Visiting Angels um, are varied and vast. Each program keeps the client focused perspective while catering to their health and wellness needs and helping the family as well. They offer various specialized care such as 24-hour home care, long-term care, specialized memory care, overnight care, respite care. Um, if Maggie wants to take a little vacation, respite care would be able to help with that. Or even just like for going to her meetings if she ends up working with a group therapy or private counselor. Um, so they provide companion care as well as personal care, social care, palliative care, and of course, most importantly, Alzheimer's care. And that is the end of my presentation. Thank you.